Thank you very much for Crohn's Colitis to invite me and Melanie to this very important talk. The Gutsy Learning Series, I remember going back 2016 was the first time we did it. And it started off in Hamilton. And quite a lot of people, I think just as many as we have here. And I know that since then it's been traveling across Canada. And it's come back to Toronto and they asked me to come and present. So my talk today is going to be on providing an overview of the Imagine Spore study, outline fecal microbiota transplant studies being conducted at McMaster Medical Centre. So the first thing I'm going to start with is the Imagine Spore study. Imagine Spore study is it's a cross-Canada initiative that has brought together a number of healthcare providers, including gastroenterologists, neuroscientists, psychiatrists, working together as a team and focusing on the brain-gut connection and the microbiome and changes in the GI-associated psychiatric disorders. The mission is to transform management of IBD and IBS and associated mental health issues with those suffering from these diseases. It's a huge investment in collaboration with Crohn's Colitis Canada and the Canadian Institute of Health Research grant that was awarded to Dr. Paul Moietti. We, as you can see here, it's a study looking at multiple sites, and in my next slide will tell you how many sites are involved. Very important study that's being conducted in Canada. We are asking for patients to commit 4 years of annual visits, and patients have questionnaires that they complete. It's quite a lengthy questionnaire. It's done online, and urine, blood, and stool once a year. If you look at this, Dr. Paul Moietti is the principal investigator of the study, and there are a number of sites across Canada that are participating in the study, and there are also more new sites that are going to be included. We are looking for 8,000 patients, 2,000 patients with ulcerative colitis, 2,000 with Crohn's disease, 2,000 with IBS, and 2,000 healthy volunteers. If you are not taking part in the study or are interested in participating in the study, you will get mine and Melanie's email at the end of the presentation, or you can get our contacts through Crohn's Colitis Canada, and we can steer you at the right center to take part in the study. Fecal microbiota transplant. Fecal microbiota transplant was intended to restore normal gut flora and to change the existing or underlying gastrointestinal disorders. It was initially started as a treatment for antibiotic-resistant C. difficile colitis. It sparked an interest in treating patients with a number of different diseases, including inflammatory bowel disease. The administration of the stool from a healthy donor to a patient is via rectal route or oral route. The rectal route is through an enema or through a colonoscopy, and through the oral route is through a nasogastric tube or an oral capsule. I know we've done a lot of basic science research in this area as well with mice studies, and we've looked at mice that were a little anxious and transferred the non-anxious mice stool into the anxious mice. It calmed them down, and vice versa. We've also done mice studies looking at overweight mice and the ones that were underweight, and the reverse effect was shown in the mice studies as well. So there's a huge amount of interest as far as fecal microbiota transplant and the treatment in different disorders. The 3 main studies that have been done and quoted, and these are all randomized controlled studies. The first one is Dr. Paul Moetti, and there's a couple of the other studies. These are being quoted worldwide and numerous times, which really has got to the fecal microbiota transplant in ulcerative colitis and IBD to the state where it's at right now. So what I'm going to do now is I'm going to turn it over to Melanie, who has been the key player at McMaster Medical Centre in recruiting patients with ulcerative colitis, and now she's doing Crohn's disease as well. She is the expert nurse at recruiting all the patients for these studies.
Hi, everyone. I'm very excited to be here. This is my baby. The first project that you saw highlighted in Usha's talk was the first FMT study that we had done. It was, at the time, Canada's largest trial. I get very excited about talking about fecal transplants. Currently, right now, I'm doing an active ulcerative colitis trial for fecal transplants. Patients would come see me or contact me via email. If they want to know more about it, you can contact me via email. I would send you the consent form and all the information about fecal transplants. In the trials, we conduct them, they're all approved by Health Canada, so we have to follow specific guidelines to be enrolled into the trial. Patients have to be active with their disease and also on a stable dose of medication for 12 weeks prior to entering into the study. No hospitalizations in the last 30 days, and also no C. difficile infections in the last 30 days that were treated with antibiotics. So on your first visit, the patient would have a flexible sigmoidoscopy to assess disease activity. And then you are randomized. It's like flipping a coin to either in this trial, we're doing an antimicrobial therapy for 2 weeks versus a placebo. Now, one thing about gut bacteria, when I first started in GI, there was never a term called microbiome. I didn't know what it was. This is a new hot topic, much like H. pylori back in the early 90s. So in order for me to describe that, I like to tell patients that there are more gut bacteria than there are stars in the galaxy. So that's a lot. It's like trying to find a needle in a haystack. We are looking to see which bacteria would be helpful for ulcerative colitis to help heal the lining of the bowel. Another good example is if I threw a big bag of jelly beans on the floor, and why are there more yellow ones than red ones? Or I really like green jelly beans, but there's only a few. What is the significance of that when we look at it as a bacteria? So we are still working on that. We haven't found the magic key yet to unlock the mystery. So one of the things that was noted was, what if we dulled down one's own gut bacteria? So that's the antimicrobial arm. It would be like on a cloudy day, there would be less stars in the sky at nighttime. So we want to dull down one's own gut bacteria so that within 3 days of finishing the antibiotics, they would receive their first FMT. Does that help patients take on the donor or the healthy microbiome better? We don't know that answer, so half of the patients are randomized to placebo tablets. So that's nothing, it's like a sugar pill. We test their stool before either the antimicrobial or placebo, and then 2 weeks after, and then every time the patient comes in for fecal transplant, they're also bringing in a stool sample as well, because we like to track what your microbiome is doing. Are you taking on the shape of the donor microbiome? So you would have 2 fecal transplants per week. They're done Mondays and Wednesdays at McMaster in our clinic for 8 weeks. And then on the 9th week, we would have another visual look with a flexible sigmoidoscopy to assess whether or not the fecal transplant has worked for you, if there was any healing done to the lining of your bowel. You also do questionnaires before and after. So this is an example of a 29-year-old male with ulcerative colitis. He's had it for the last 17 years. He had failed the steroids and azathioprine. His Mayo score was a total of 9. His endoscopy score was 3, which was a severe disease activity. And after having the fecal transplant, he actually went into remission. So this was done at week 9, where they show the active and then a nice pink healthy colon at the bottom. Currently, right now, I've enrolled about 69 patients in the study, and my goal is a total of 80 to complete the trial. So I'm hoping to have all of that done by spring. At that time, we will study and look at all of the data and publish it as well. Now, I've recently started a Crohn's disease study as well, and this is done out of Alberta, and we've become the next site on board. I started it in October, and I have about 13 patients into that trial that have completed, and also it's currently on a pause right now, but we're looking to start again in January. Again, by Dr. Moyetti, Dr. Marshall, Dr. Smeederhalder as well. In that trial, we're looking to put patients into remission. Now, I know the protocol says mild to moderate in the title of the study, but if the endoscopy score is severe, actually patients aren't excluded, which is a nice thing. So you would be able to enroll. At baseline, patients complete blood work. We do a disease activity. I would do all the stool samples and blood work that would be done to make sure you don't have any bad bacteria prior to entering into the study, like C. diff, salmonella, anything like that. We would treat you for it if you did. At week 0, you would have a colonoscopy. And that is where you're randomized to either a real FMT spray, so fecal microbial transplant spray, or water. We go in and we spray the bowel down, and then once a week you would come and see me for capsules. They're actually frozen, and patients ingest them frozen, and they're timed release to open up where we would like them to open up in the bowel. You would come once a week for 7 weeks, and on the 8th week, you would have a repeat colonoscopy to assess disease activity. Now, if you were randomized to the placebo, you have a chance to go into the active treatment arm as well, which is a nice, that's a nice, you're not just stuck at having a water enema and not being able to have the real treatment if you would like the real treatment. Each one of these visits are done within 40 minutes or half an hour to, in the first trial, I'm sorry, I didn't mention the route. The ulcerative colitis, patients lay on their left side, and we introduce it as a fecal enema. It's just a slurry of bacteria that's introduced into your rectal area. For the Crohn's disease study, in this one here, it's done by capsules. One of the questions that most patients have about ulcerative colitis when it's introduced into the rectal area is, will I be able to hold it? What if I don't? There are a lot of patient worries around that area, and the bacteria is in its natural place. We're putting it in the rectal area. That's where it came from. It's not a fleet enema that is designed to say, I need to go to the toilet. So patients are able to hold it for 20 minutes. If they don't hold it for 20 minutes, we found that the bacteria start replicating right away. So with that, we'll move to the next slide. So globally across Canada, between the 3 sites, we're looking at recruiting 126 patients. I've screened about 21 patients, enrolled 13 so far. I have another 13 ready to go in. There was a Health Canada warning. It came from the FDA in the United States. There was a complication. One of the hospitals did not test for an antibiotic-resistant organism. So all the trials were put on hold until all your data was submitted to state that at McMaster, we tested for those issues. So we're just waiting for the hold to be lifted, and I'll be ready to start. This is in the Crohn's disease study. This is before treatment and after treatment. And I can't say enough about, I just have such a passion for it because it is a natural treatment, but I must tell you all that it works in some people and it doesn't work in others. I don't know why it works in some people and why it doesn't work in others. That's one of the basis of our research project. Looking for those magic bacteria. The study that Usha talked about at the very beginning, that study was brought upon from the first ulcerative colitis trial that myself and Dr. Moyetti did, where we put 25% of the patients into remission with fecal transplant. And that just stemmed the whole process. What bacteria is beneficial? So in that large project that Usha was talking about, we're looking at 2,000 ulcerative colitis patients, 2,000 Crohn's, 2,000 healthy, 2,000 IBS, and we're looking to see, are the ulcerative colitis patients, are they missing this, and this bacteria compared to healthy controls? Are the Crohn's disease patients, do they miss this bacteria? Those are things that we don't know. There's never been a large study like this, so I'm pleased to announce that that is Canada's largest trial to be done on gut bacteria for ulcerative colitis and Crohn's disease, and it hopefully will be the world's first publication in that. So I'm really excited about that trial as well. I get excited.
So with Melanie's excitement, if you're not in the Imagine Spore study, and if you want to know where there is Imagine Spore study that's being done, you can contact us or you talk to your doctor and take part in this study. It isn't very onerous. Once a year, stool, blood work, and urine test. The questionnaires can be done online. I must say, what I've heard from patients is that the questionnaires are quite lengthy, but you can do it in different sittings. You don't have to do the whole thing at once. It takes about an hour, hour and a half to do, so it can be a little bit time-consuming.
Because we want to know what Canadians are eating, whether they're having a lot of fish, salt, there's all of that in there, so the questionnaire does take a long time to complete, but we want to know what you're eating, what you're drinking, milk, dairy, non-dairy. That's the important part about the gut bacteria.
So that brings me to the final FMT project that we are doing at McMaster, and that's FMT for active pouchitis. And the principal investigator for this study is Neeraj Narula, and as Kate mentioned earlier, Peter is the study coordinator for this study. So I don't know how many of you know about pouches or not. Many patients with ulcerative colitis undergo a colectomy for a number of different reasons, and then they have an ileal pouch anal anastomosis, whereby they have the colon removed, the rectum is still in place, and they create a pouch using the small bowel, and that's attached to the rectum, so then you can go and have a bowel movement rectally rather than through an ostomy. 50% of patients experience pouchitis or inflammation in the pouch. When you have a pouch, you have frequent bowel movements, and when you have pouchitis, you have a lot more bowel movements with urgency. Alteration in the microbiome is the most effective management of pouchitis, and that has been done with using antibiotics as well as probiotics. And about a third of the patients become dependent or refractory to these forms of treatment. So we have started doing FMT for pouchitis. It's a single center study, so it's FMT versus placebo for 4 weeks, and then you have an option after the 4 weeks to get the open label FMT transplant, and that is done rectally with an enema. So this is what the study design looks like. You come in, we obtain a consent, a flexible sigmoidoscopy is done just to assess the pouch, do some blood work, and we do an assessment score to see the degree of pouchitis, along with are you eligible to participate in the study. You receive 4 weeks of weekly enema, FMT or placebo, and then at the end of that time, you would undergo a flexible sigmoidoscopy, and you're unblinded, and if you did receive the placebo, then you get an additional, I think 4 weeks, so 6 weeks. Peter, 6 weeks, is it? 6 weeks, because I said 4 weeks before, so it's 6 weeks, sorry. We have completed the first 5 patients in open label. So we did a feasibility to see if this really is going to work on patients using 5 patients. And we've completed that. Now we've started the randomized FMT study. And the 4 patients have completed the intervention, I already said that, and had a lot of improvement in the pouches, in the pouch. So if you look at the pouchitis, the upper images of the scope shows how much inflammation there is, and after treatment, how it has improved. It's dramatic. I mean, as you can see, if you've never seen this before, you can tell the difference. I was fortunate to get the Canadian IBD Nurses Grant in 2017 to study the patient perception of fecal microbiota transplant. We've completed the study. It's a first qualitative study looking at patients' perception of those that went and had an FMT, were participating in the FMT, and those who refused. Very important question, because there's also, people are thinking about, the yuck factor or the aversion to the fecal microbiota transplant. We've completed the study, done the data analysis. We're going to be, some of the data analysis is still being done. We're going to be presenting an abstract at the upcoming conferences. And what I can say is that education is very important. So patients that are informed and educated, even those that refused to take part in the study, sort of change their mind. The yuck factor, it is there, but because they look at it as natural and they have somebody keen like Melanie presenting the study to them, that the yuck factor is not really a big deal for the patients. And they look at it as a treatment option. A lot of the patients that we did enroll in this perception study, it was a last resort to take part in treatment because it failed medical treatment. So they look at it as a last effort to get better before surgery as an option. So we're just going to be completing the analysis, and we'll be doing a publication on this study as well. But it's interesting information that we have received, and it's a first qualitative study looking at the patient side of things. As in summary, we've talked to you about the Imagine Spore, which is a big study across Canada. It's an important study, and we've also looked at some of the other work that has stemmed from the Imagine Spore study, like the FMT study. And if you need to contact me, you can contact me at the IBD clinic at hhsc.ca, and Melanie Wolf's email address is there, and Peter is there as well. So with that, I think we've got question and answer period now. Okay, thank you very much.